Good morning, everyone, and welcome. I'm Lana Comstock with Iowa Healthcare Collaborative. Today, we have our webinar. It is the Opioid Guardianship Upstream Prevention Tools and Best Practices. So I will be facilitating today as Sarah Durr, our management specialist and lead, is out. I must make sure that I share with you that to obtain nursing contact hours, you must have entered your license number at the time of your registration. You must be logged in individually with a unique email address to the webinar for the full duration of the presentation. This is how we validate your attendance for our providership for the Iowa Board of Nursing. You will receive an email link via that email that you've provided for evaluation, and basically all disciplines will receive a certificate of attendance with exception to nursing, and you can print that for your education. There are a few housekeeping notes. We want to mute our lines. This will help with our quality of our presentation today and prevent disruption. Please make sure that you utilize the chat box, and we will moderate any questions or comments you have. I have feedback from Kim that there's a great amount of feedback. I'm going to just say what's happening is if we have people who are on the telephone line and utilizing their audio, that might be one piece of what's happening. Muted. All right. I wanted just to give a real quick update. We continue to watch the legislative outcomes related to the opioids, and once the bills that have been presented are passed into law, we will be sharing that information. Sarah Durr is the one who is trying to track those for us. Many of our hospitals are engaged in the opioid guardianship program. We have 40 hospitals. They basically what's happening is you and your teams are getting together, you're reviewing data right now, just really trying to focus on what are those current prescribing practices for the opioids, and that'll help as we move through the project and the work we're doing. With our webinars, we do encourage you to view not only the training webinars such as today, the main webinars with your opioid project teams, either live or after the recordings. We share those on our Innovation site, and it'll just be a team process. As you know, today we're going to review some best practices. We're going to take a look at opioid initiation therapy, utilization of tools, and tapering of opioids and benzos. So without further ado, I am going to provide you a little bit of information. Today we have the pleasure of having Jolene Smith with us. Dr. Smith is a pain management physician. She's certified in pain medicine and physiology. She serves as a consultant for Boston Scientific Corporation and the chairperson of the Pain Management Mercy Hospital. In her role, she serves as an advisor to medical staff about managing acute pain. And additionally, Dr. Smith serves as a medical preceptor in her personal and professional commitment to assure education about pain management. So without further ado, Dr. Smith?
Yes, thank you, Lana. Can everybody hear me?
Yes, we can hear you well.
Okay, great. So do I have control of the slides, or how is this going to work?
Dr. Smith, if you just asked me to advance the slides, I'd be more than happy to.
Okay, great. You can go ahead and advance to the learning objectives slide. So what I will be talking about briefly today will be really talking briefly about the guidelines, but really about how to appropriately manage these patients, when to initiate therapy, especially with opioids, and how to keep your practice safe when initiating opioids, especially in the setting of non-cancer related pain. By the end, you'll be familiar with the guidelines, specifically the CDC guidelines, and how they, how they've been interpreted and how they should be utilized. We'll briefly talk about that when initiating opioids for different conditions, such as non-cancer pain versus acute pain, and so on. We really have to be considering different thought processes when it comes to initiating these opioids. We'll talk about why patient history and concomitant medications are important to evaluate while you're doing these initiations of opioid therapies. And alternatives to opioids, that's a big part of the push these days. We'll talk about adjuvant medications. The definition of adjuvant is anything that provides analgesia.
Hold on just a moment for us, Dr. Smith.
Am I back on?
Yes, you are. Thank you.
Okay. And then at the end, we'll talk about some dosing parameters, some of the published guidelines, and then the research. The outline we can briefly look at if you want to advance that slide. Perfect. This is our outline. Yeah, you can print, or you can put this whole slide up.
Okay.
So the reason we know opioids work is because we know the mu receptor provides analgesia. So the way pain transmission occurs is you have a peripheral stimulus, so a painful stimulus that is sensed by the pain fibers, typically small fibers, small C fibers and A delta fibers. Those pain signals then travel to the dorsal column of the spinal cord, so the posterior part of the spinal cord, at which point they ascend into the brain. So pain is interesting. So there's two pathways for pain. One is the somatic pathway. So that pathway travels directly to the cortex of the brain. This is the protective part of pain. So essentially, I put my finger on a hot stove. My body tells me, ouch. My brain basically instructs my hand to remove my finger. So that's the somatic, or the conscious part of pain. Now, pain is interesting because there's two ascending pathways, like I mentioned. The other pathway goes into subcortical regions in the brain. Those are more of the affective part of pain. So, for example, the amygdala, the hippocampus, and so on, when those sense these painful signals, you get suffering. That's why pain hurts, okay? Pain hurts not just physically, but emotionally. And it's important as we talk about chronic pain that we address pain from both of those standpoints, not just from a physical ouch standpoint, but also how it might impact our patients on an emotional level. We can go to the next slide. So there are several types of pain. There is acute pain and chronic pain. And acute pain is essentially you have surgery, you injure yourself, you break a bone, you're going to have acute pain. Chronic pain is unfortunately the maladaptation of acute pain. So this is persistent pain that is persisting beyond the expected time frame of typical healing. So for a broken bone, somebody with pain after 6 weeks may be considered chronic. For something like a major abdominal surgery, pain after 3 months may be considered chronic. Chronic pain is what we treat. This is why I have a job and show up every single day. Chronic pain has many parts to it. So nociceptive pain is more of the tissue pain. So this is the somatic pain, or the bones, joints, tendons type of pain. Neuropathic pain is pain originating from either central nervous system structures or peripheral nervous system structures. And then you have mixed pain. So the majority of the pain out there is low back pain. You can see 55 million people suffer on an annual basis with low back pain. And then fibromyalgia also is a significant component of chronic pain. These are mixed pains. So they can be difficult to treat, but there are ways to do that, and that's what we will be talking about. All right, go on to the next slide, please. So definition from the CDC basically defines chronic pain as either lasting greater than 3 months, or like I had mentioned earlier, past the time of expected normal tissue healing. We don't really understand why some patients have more of a predisposition to developing chronic pain, but we know some data that supports uncontrolled or mismanaged acute pain is one of the risk factors for developing chronic pain. From this study from the National Health and Nutrition Examination Survey back in early 2000s, then they stated 15% of adults have current chronic pain. Where that number is today, I can imagine it's greater. But again, we'll continue on with these CDC guidelines. I think that's why we're all here. This is when it became more of a national outcry. The second the CDC guidelines dropped, everything started to change. And now we've really reevaluated our prescribing practices and are trying to figure out how to appropriately manage our patients without having the pendulum, swing in the opposite direction. So the CDC guidelines were specifically developed for primary care providers, okay? Primary care providers are treating outpatient patients, okay? Most of the time, they are providing pain management for patients without cancer, without acute pain, or without end-of-life or palliative care. So the CDC guidelines are specifically for outpatient, non-cancer patients who are seeing their primary care provider. The general overall consensus of the guidelines is, as we would all expect, consider non-pharmacological or non-opioid therapy first. If you need to establish an opioid regimen, you really need to discuss goals prior to initiation. And these have to be not just the provider's goals, but patient's goals as well. You only should be continuing therapy if you feel it is improving both pain and function. We'll talk about why some of our pain societies have not really liked this statement, but we'll get into that. And then, of course, when prescribing, always start at the lowest effective dose, and then avoid extended release when possible. And then always reevaluate. These patients need close periodic follow-up. So the next slide talks about the Iowa Board of Medicine position on the undertreatment of pain. So they basically say they know it's a serious health problem, okay? They know that untreated pain worsens patients' functional status and quality of life. They know the undertreatment of pain is a departure from accepted standards in the practice of Iowa. So that's their state, so their state of mind. So basically what they're saying is we need to treat pain because it's helping with patient function and overall satisfaction. So standards of practice coming again from the Iowa Board of Medicine. This is pretty straightforward, and this is what we see all over, including the CDC guidelines. You need to evaluate the patient. You have to come up with a plan. You need to set goals early on. You need to inform the patient of any consequences of therapy. Close review, meaning frequent follow-ups. Consider advanced referrals to help so that you have alternatives to try outside of opioids. If a patient proves to be non-compliant, then termination of care should be considered. You need to document. If you're checking the PMP, if you're doing urine drug screening, you need to document that you're doing those things. Otherwise, somebody who's going to come audit your charts, if you have a bad outcome, is not going to realize that you were doing your due diligence. Pain management agreements, these are very important. This keeps the patients accountable. This will give you something to fall back on, especially if there's a breach in contract. Understanding patient history is also very important. Multiple significant medical comorbidities will increase risk with opioid medications. It's important to understand that. And then, of course, doing drug testing, not only to ensure that they are taking their prescribed medication appropriately, but to evaluate whether they are using either illicit substances or non-prescribed substances. So the American Academy of Pain Management is one of our big national pain societies. Now, they've come out with some statements and some disagreements with how the CDC guidelines were portrayed. So again, I mentioned earlier that the guidelines state that you should be showing both an improvement in pain and an improvement in function. Now, it's difficult for a lot of our patients to achieve both of those parameters. And so the AAPM doesn't necessarily like that those two parameters are an absolute. The preference for our society, AAPM, would be to document progress towards goals. So everybody's goals are obviously going to be different. And the goal is, of course, pain reduction and functional improvement. But if a patient is able to be stable, even without ongoing improvements, stability is also very important. And so as pain providers, we understand that not everybody can get back to working, a full duty job, but they may be able to still be active members in society. And it's important that we document these goals and whether our patients are meeting them, and not just say, you did not reduce your pain score, you're not back to work, so therefore you're not a good opiate candidate. Another statement that the AAPM said is it's very interesting. So they say for acute pain, especially for acute pain, they don't really go into differentiating, at least not in the big print. In the small print they do, but differentiating the different types of acute pain. So we know that an acute back strain is going to be treated and require treatment that's different than a broken bone or a major operation. But the CDC doesn't really give us good guidelines. Their blanket statement basically says that acute pain should improve within 3 to 7 days of opioid therapy. We know that that's not the reality, and the AAPM says that we as providers need to understand that we just have to use our best judgment, but that's not realistic to treat everybody, to put everybody in the same pot when we're dealing with acute pain. So we need to understand what would we expect for a given injury and come up with an early goal. If you say that your broken bone should not require more than a week of opioids, you tell that to the patient up front so that they recognize that they can't call for a refill, but that if they struggle, you'll reevaluate and determine why they continue to have pain. It's these communications with patients up front that ultimately sets them up for success, as opposed to them feeling abandoned because all of a sudden their prescription ran out and now they don't have a plan and they still have pain. So setting these expectations early is important, and understanding that acute pain does not and should not all be lumped into the same category. We can go to the next slide. So the CDC guidelines also talk about using caution when your oral morphine equivalent dose gets above 50 milligrams per day, and rarely should you require more than 90 milligrams of morphine equivalents per day. Now, these are recommendations. These guidelines are placed as recommendations, not as absolutes. So when we are seeing patients and they are stable, and they may be stable on a dose higher than 90 milligrams of morphine, and you can document that they are achieving their goals, that they're not having side effects, that there's no significant problem with their opioids, it may be reasonable that they stay on a dose that's higher than what's listed. Unfortunately, many primary care clinicians have interpreted these as thresholds, and in my office, I'm getting several patients who feel abandoned as they're told they can no longer receive that dose because it's against the law. And I think we need to just understand that these are guidelines, they're recommendations to help guide us in our practice, and the majority of your patients should not be above this, but those select few that are, if they are doing well, it might be something reasonable to continue. So the other, which we all strive for, if you go to the next slide, what we always want to do is we want to push adjuvant therapy and non-medication therapy. The problem is we know that the highest misuse of opioid medications are in rural areas. Heroin and other drugs of abuse are higher in these communities. And unfortunately, it's because the resources aren't there. There's not a board certified pain physician. I can guarantee it. There's probably, I think I counted 20 in the state of Iowa. There's just not enough people available to help these patients, and the funding for these supportive, alternative things such as psychology, therapy, closeness of advanced practitioners. It's difficult. And so although that's of course the recommendation, until we get better support on a national level, this is going to continue to be a problem. And so at least with our practice, we've really been trying to increase and improve our education on this matter so that those in rural areas know what other things to try, including things that they have at their disposal, so that they don't get down the path of high dose prescribing, because we know that that's not sustainable. If we go to the next slide here, so the goals of the CDC guidelines overall is to take all steps possible to minimize exposure of opioids when treating chronic pain. Okay, so the AAPM basically says that's great, but this goal must be done in a way that does not harm the vast majority of people using opioids to manage their chronic pain, who do have positive benefits compared to risks, who do not misuse or abuse their medications. So again, we want to make sure that we're not abandoning the patients who are benefiting from these medications, and that we use these as guidelines. So the APS, the next slide, is a different National Pain Society. They have some different statements. So they basically say the doses and times listed in the guidelines are not based on risk-benefit studies, but rather risk studies alone. There are no studies that, at least not out and not well read, that talk about the benefits of opioids in the long term. Now, does that mean that they don't benefit people in the long term? We don't know, because we haven't studied it. But we do know that there is risk, okay? So it's important that when we're using these guidelines, we understand that they were developed based on risk alone and not whether or not there's a potential benefit. And I had mentioned earlier, the media has said, there's no real differentiation between acute pain. What constitutes acute pain? And if you read the guidelines in the small print, it does talk about that the recommendations are not for pain after trauma or major surgery. But again, it's not readily available in the guidelines, and you'd have to be searching for it. And then the guidelines also disregard or do not address when's the right time to consult a pain expert. And that would be very important because, we provide a service that primary cares, don't have at their disposal. And we consider ourselves experts in the area, since this is all we do. And the guidelines didn't really talk about, when to place that into the algorithm of treatment of these patients. So we'll move on kind of beyond what the pain societies talk about. So when you select patients for opioid therapy, you have to know what type of pain you're treating, what therapies they've tried previously. You have to understand their history and physical to do a risk-benefit ratio. And you need to be screening for risks of abuse. This should be done on every patient who you're considering opioids for. When you do patient monitoring, okay, you should be doing a reevaluation of their function, of their pain, and then whether their side effects are, or whether they have side effects or other risks versus benefits. Everybody should be checking the PMP. This is available throughout Iowa. Do I check it on every patient? Most of the time I do. If it's an acute prescription for, a known broken bone, would I? Not necessarily, but anybody being treated with chronic pain in our office, before we sign that prescription, the PMP is run. We do routine urine drug screens on patients who we have no issues with. We're typically doing this yearly, but part of our pain contract that we have them all sign, we have the ability as their provider to bring them in unannounced to do a random urine screen. Red flags, anytime there's a history, family history included of substance abuse, that's considered high risk. Whether they've got PMP hits, meaning somebody has reported them for something that they've noticed inappropriate, that's a red flag. And then concomitant mental health diseases, including uncontrolled depression or anxiety or active or even quiescent psychosis, can be problematic. Adjuvant medications, again, these help improve pain while reducing the need for opioids. There's several categories of them. We can move quickly through this. The next slide just lists several of the antidepressants. Antidepressants can be specifically used for painful conditions such as Cymbalta, but also we know that there's a cycle of pain which includes some type of mental disorder, most commonly depression or anxiety. By just treating that underlying psychologic disorder, we may also improve pain. And so utilizing antidepressants early in somebody with chronic pain is important. There are different categories of anti-inflammatory drugs. If patients do not have risk factors, these are important, or these can be important medications to consider. There are different classes of anti-inflammatories. If they fail one class, try to flip to a different class before you consider it a failure. Anticonvulsants, we know especially Lyrica is FDA approved for the treatment of postherpetic neuralgia. These are used quite often. They can be helpful for neuropathic painful conditions. Okay, some of these require laboratory studies to follow, especially blood counts. Some can increase the risk of suicide. Most commonly, this is in younger people. But again, multimodal therapy from different drug classes can be helpful. Muscle relaxants, they work by providing CNS depression. Only a few actually target the muscle directly, but rather they relax the nervous system and helpful in patients with chronic pain. What we do mostly as pain physicians are interventional modalities. We try to treat pain through needles. Needles have the least amount of side effects compared to anything else, especially medications. I'm not talking about physical therapy, occupational therapy, etc. But we do injections every single day. We target every area in the body that has a painful condition. We will try multiple things to help treat the source of pain prior to covering up the reason for pain. And when what I consider more conservative procedures to have failed, we also utilize implantable devices that can help reduce chronic painful syndromes. So initiating opioids, the first question you need to ask is my patient opioid tolerant or non-tolerant? Opioid tolerance is going to change your starting dose. Okay, so looking at the fentanyl labeling, somebody is considered tolerant if they're on 60 milligrams of oral morphine daily. Some people have different parameters of that, but that's a pretty good place to start. And anytime you initiate an opioid, if you have any question, the drug insert, the package insert will clearly talk to you about appropriate initiation doses. Some will have conversion tables. When in doubt, start at the lowest effective dose. Opioids are CNS depressants. Anytime you use them with other CNS depressants, you can run into trouble, specifically benzodiazepines and alcohol, okay? You need to have a clear risk-benefit discussion with patients if they are using more than just one CNS depressant, because an acute illness such as a pneumonia can set them over I don't know what last part you had heard, but when prescribing opioids with other CNS depressants, you have to be very careful. If you have somebody who has respiratory depression, because of concomitant use of these CNS depressants, you will be held liable. Some states are actually doing manslaughter charges if you have a patient who you prescribe to who is admitted for respiratory depression or is considered to have died while being prescribed certain medications. Iowa is not one of those states, yes, that's doing that. So I'll conclude here. I know others have time to speak, but basically the CDC guidelines are guidelines. They're used, or they should be used as helpful guidelines for primary care providers on appropriateness of using opioid therapy for their patients with chronic non-cancer pain. Risk benefits and early setting of goals is very important. You need to have a plan for discontinuing, tapering, for when your patients either become too high risk or have where they've diverted or they've misused. You have to have a plan in place. It's important that if you recognize an opioid use disorder, that you provide those patients with referrals or at least with phone numbers for local treatment facilities. That's part of our due diligence. Frequent reevaluation of patients is always necessary and important, and consider adjuvant therapies, consider consultation with a pain specialist prior to making drastic changes in these patients who you're not quite sure how to deal with. I've got my references at the end. Are there any questions that anybody has? Otherwise, I'll pass the mic on.
I'm going to go ahead and take a look at our chat box just to see if anybody's placed anything in there. At last check, they had not. No questions at this time, Dr. Smith, so we'll keep watching that.
Okay.
Thank you so much for presenting today. Really appreciate it so much.
You're welcome.
We have a large group on our call today, so I'm just going to do a quick reminder to everyone about assuring that you are muted. I have muted everyone. I'm going to mute all again, and then we're going to go ahead and introduce our next person. So our next speaker is going to be Jill Duffy. I would like to let you know. Hey, Jill, I'm just going to check with you. Do you have both audio on your computer and on the telephone?
I don't know if I have.
That's what it sounds.
I have my phone on because I know that has a speaker.
I think we've had some people talking about some swishing, so I just want to make sure that how does it sound to everyone who's listening? I'm getting a little echo. Is anyone else? Can you type that in for us? Jill Duffy's been a registered nurse for more than 25 years and an advanced registered nurse practitioner for nearly 5. Jill shares that her interest in pain management had actually blossomed when she was pursuing her bachelor's degree. Jill's work includes medical, surgical, hospital work, and in interventional pain. And she had worked at the Interventional Pain Center in Fort Dodge. Jill's maintained her board certification in pain management nursing since it was even initially offered, and that was in 2005. After receiving her advanced registered nurse practitioner degree, Jill worked through primary care for a year, worked in primary care for a year, and then she returned to the world of chronic pain. Jill, we're really eager to hear you regarding the risk assessment tools that you're going to talk to today. And I will take a quick look at what's happening with our volume. Thank you so much, Jill, and I will proceed.
Hi, good morning. Next slide, please. Okay. Chronic pain is defined by the International Association for the Study of Pain as pain that persists beyond normal tissue healing time, which is assumed to be 3 months. So chronic opioid therapy would be considered when chronic non-cancer pain is moderate to severe with an adverse impact on function or quality of life, and the potential benefits would outweigh or are likely to outweigh potential harms. Today I'm speaking on the tools for risk assessment and stratification of the risk. All the following forms are easily available on the internet, and you can see the top identified risk factors, which include personal or family history of aberrant behaviors, history of physical or sexual abuse, and co-occurring psychiatric conditions. Mood and anxiety disorders are prevalent in chronic non-cancer pain patients and are screened in most offices and facilities by using the PHQ-9 Patient Health Questionnaire and the GAD, or the Generalized Anxiety Disorder, which is less frequently. I think the PHQ-9 is pretty much mandated to be tested for most patients that show in offices as one of the quality assurances that the Medicare, Medicaid requests. Next slide. Opioid risk tool is one of the tools that you use prior to initiating or considering opioid therapy. This tool should be administered to patients before you even consider treatment for them. Next slide. There are different values on this tool for both male and female patients. And can you go back one? Questions asked include the family history of substance abuse, the personal history as the age of the patient, and any history of pre-adolescent sexual abuse. Psychological diseases are included in this scoring. Depression is indicated as its own point, and anxiety is not included in this one. Next slide. Takes less than a minute to administer and score. This is done by the clinician rather than the patient, and it will separate in between low, moderate, and high risk. Next slide. A second screening tool that is frequently used is the SOAP-R, which is the Screener and Opioid Assessment for Patients with Pain, revised. This is a total of 24 questions, and it predicts the possible abuse in patients with chronic pain, and it assists with determining how much monitoring that patient may need. Next slide. Their high-risk patients will indicate a history of behaviors and beliefs. This form is filled out by the patient, and there's no right or wrong answers. It's using a never to very often 5-point Likert scale, and includes questions such as, do you have mood swings? How often do you feel bored? How often have you been arrested? It checks for current or recent history of alcohol and drug abuse, if they've been discharged from care before due to behavior, and kind of lets you know what their compliance is with previous providers. Next. It does provide excellent discrimination between high risk and low risk patients, and a high risk score on the SOAP-R correlates with increased likelihood of drug abuse. And remember, these are all screening tests and are not hard set numbers that if they're above a certain number, you don't give them the option for chronic opioid therapy. Next slide. Clinically, a score of 18 or higher will identify approximately 81% of those who turn out to be high risk. And most people that score below are likely at low risk. Takes about 5 minutes for the patient to administer and for the clinician to score. Next slide. Next slide, please. The DIAR, or also the Diagnosis, Intractability, Risk, and Efficacy Scoring, is also used prior to consideration of any treatment with opioid therapy. This is more for patients that have been on opioids. This is done by the clinician. Next slide. The diagnosis has a differentiation between benign or slowly progressive or advanced conditions. A benign condition would be an example as fibromyalgia, migraine headaches, or nonspecific back pain. Slowly progressive conditions include failed back surgery, and the advanced condition can include severe ischemic vascular disease, advanced neuropathy, or severe spinal stenosis. Intractability starts with can you go back, please? Therapies that have been tried versus customary treatments have been tried versus they're fully engaged. The psychological includes severe personality dysfunction would be 1 point. 2 points would be there's a personality or mental health that may interfere moderately, such as depression or anxiety. And 3 is a good communication with the clinic and no significant psychological dysfunction. Chemical health would range between active or recent use of illicit drugs versus being a chemical coper with a past history or no chemical dependency history. Reliability ranges between numerous problems to occasional difficulties to highly reliable patients. Social support would look at the patient's life in chaos, which would be 1 point, versus reduction in some relationships and life roles versus a very supportive family and involvement in work or school with no social isolation. Finally, efficacy does between poor function or minimal pain relief versus high dosing of medication. Moderate benefit with function improved in a number of ways, but we haven't really tried a lot of opioids, or they've tried very short trials. And 3 would be a good improvement in pain and function and quality of life with stable doses. Next slide.
Jill, before we move on, may I ask you to move your telephone away from your computer screen?
Okay.
I am looking, and it looks like I have everyone muted, so that's the only thing I can come up with. But we are having some technical and sound issues, so we would appreciate that. Thank you.
Is this better?
Not really.
I'll take it off speaker. All right. The DIAR score ranges between 7 and 21. The higher the number, the more stable they would appear for opioid therapy. Next slide. The DIAR has a cutoff at 13 between high and low risk, and it can take less than 2 minutes for it to be completed. Once opioid therapy has been initiated, we would use the option of the pain assessment and documentation tool. This is a form that can be used by clinicians that asks multiple medications, what analgesia they're using, and activities of daily living. Most of these are going to be found in your exam note. But most important for this is where the development of the 4A's came from. And this is a way to determine potential aberrant behaviors. The 4A's include analgesia, activities of daily living, adverse effects, and aberrant drug-related behaviors. Next slide. This is a clinician-directed interview. Parts of it is completed by the physician, the nurse practitioner, assistant, or nurse. But the aberrant drug-related behavior and assessment sessions are by the provider. Next slide. These are a list of the potential aberrant drug-related behaviors that you're looking for each time you see your patient. Next slide. The current opioid misuse measure is a tool that we use to once care is initiated. This does not assess for tobacco, alcohol, or other substances of abuse. And it helps to check for the aberrant behaviors during treatment. Next slide. There are 17 items involved in this, and it can take less than 10 minutes for the patient to complete. It assists with leveling monitoring and or justifying referrals to a specialty pain clinic. It's not a lie detector. Questions included would be in the past 30 days, how often have you had trouble with thinking? How often do people complain you're not completing necessary tasks? And it kind of gives a nice measure of how things are going. Next slide. Scoring above 9 is positive, and we remember sensitivity is a true positive where the person is correctly identified, such as you're a sick person who is really sick, versus specificity, which is a true negative, so a healthy person who is not sick. So these are all validated scores with lots of research in the background. Next slide. And classifying risk. Next slide. There's many different recommendations, and I tend to use in my practice those that have been established by the Veterans Administration. So a low-risk person would have a physical examination that matches their subjective accounts. There's medical imaging and lab findings that also provide objective results for a subjective report of pain. Patients would have a high level of acceptance and coping strategies. They're motivated and they're trying to function at their most normal level and progressing towards their treatment goals. Next slide. Moderate level of risk for opioid use would be as the same with the low, but they have more than 3 areas of pain in their body. This can be folks that have low back pain with sciatica, they may have fibromyalgia, and they may have headaches. The moderate comorbid psychological and medical problems are well controlled with active treatment, and the risk factors for medication misuse and abuse are minimal. Next slide. A patient that would be considered at high risk has widespread pain without objective signs or symptoms. They may have unstable or untreated substance abuse or psychiatric disorders, or they may have some suicidal or homicidal ideations. They have a history of or current aberrant behaviors that are related to medications or drugs, and they're not willing to participate in a multimodal therapy, and they're not functioning in what would be considered a normal lifestyle. Next slide. So once you have your patients on medications, next slide, one of the screening tools or the best tools to use before, during treatment would be the prescription monitoring program. This will help identify potential diversion, misuse, or abuse of controlled substances. It will report controlled substances from level 2 down to level 4, which would include opioids, benzodiazepines, and stimulants. Next slide. Each registered practitioner may authorize up to 6 different agents to act on their behalf. The pharmacies are submitting the information on a weekly basis. So a week goes from Sunday through Saturday, and the suspension of the medications are to be submitted by the following Wednesday. In the many years that I've used this, there's only been a few times that there's been a lag in there, and I think that was technical difficulties. The in-state pharmacies report to the Iowa PMP, and all non-resident pharmacies are to report to this if the patient is living in Iowa. Next slide. They currently in Iowa, we have the capacity to look for the following states. And just as an offside, Missouri is the only state of the 50 that does not currently have a prescription monitoring program up and working. Next slide. There's a ton of information that is available through this. You can look and see patients' names and their aliases, how many different addresses they may have lived in. It will show the fill dates, which is actually the dates dispensed by the pharmacy to the patient. The medication name, dose, and formulation is on there. Their quality and how many days of medication for that prescription. It allows you to look at the prescriber, the date the prescription was written, and whether it was a new or refilled medication. It will show the pharmacy that the patient filled the medication at, and it also shows the payer. So these does give you a lot of information if you see someone that has a lot of little short refills or they overlap. If they're on a controlled medicine that's on a scheduled basis, but they're filling instead of every 30 days, they're filling every 40 days, you kind of have to wonder how they're using that medication, which gives you as an excellent opportunity as the provider to talk with that patient about how they're using their medications. And then next slides are my references. And we, like I said, at our pain management center, we are actively using the ORT, the DIAR, and the 4As on a regular basis, and we hope to soon initiate into the COMM on that also. Thank you. If you have any questions, please let me know.
Well, thank you so much for presenting that information, and I'm glad that we had the opportunity to learn a little bit more about those risk assessment tools and learning what you're currently using in your practice. So thank you so much, Jill.
Mm-hmm.
So as we get set up here, we're going to have another speaker today. Our next speaker is a pharmacist, Jarek Vetter. He's going to present on the focus of medication interactions and then tapering of opioids. Jarek is a pharmacist at Broadlawns Medical Center. He serves as the pain clinic pharmacist that's on staff and also at the Pain Management Center. He obtained his degree at in pharmacy at Creighton University. He's certified in compounding. And Jarek, we really look forward to the information you're going to be providing us today. And I'll have you go ahead and start, and I'll just advance the slides as you ask me to.
Can everybody hear me okay?
You might need to speak up just a little bit.
Okay. Well, I'm honored to be here today. I'm bringing up the caboose here, so we're gonna just kind of finish off your day with tapering and drug interactions in regards to opioids. So, next slide when you're ready. So the objectives here, they're pretty straightforward, but we're going to identify some of the risks of high risk interactions with opioids. They were mentioned earlier, but we're going to get a little bit closer look at it. We're going to review CDC recommendations for opioid tapering. We're going to just touch on one of the Katrina protocols for opioid taping that's a little more aggressive. And then we're going to discuss some of the common supportive medications that you can use while tapering as well. So fairly recently here, it's actually been within the last few years, there's a black box warning. This was mentioned earlier, but opioids now all carry this, and any new opioid that comes out will automatically have this on their as a black box warning on their package insert. Concomitant use of opioids with benzos, CNS depressants, alcohol, or may result in profound sedation, respiratory depression, coma, and death. I won't read that whole thing there, but it's certainly something that patients do need to be aware of if they're on both of those medications. Providers also need to be aware when they're prescribing both of them that all of these are going to carry increased risk, and we need to do some extra monitoring. Next slide. So we got a little brain freeze going on here. CNS depressants, and they were mentioned earlier, but alcohol would play in here. There's quite a few benzos that are listed on the next slide. Muscle relaxers, and just a couple examples listed there. Mood stabilizers as well, and then sleeping medications. All of those are examples of CNS depressants, but benzos are ones that are specific that are going to. They all carry that increased risk, but benzos specifically are going to be at a higher risk. And what happened is the VA hospital actually did a retrospective analysis between 2004 and 2009, and what they found is that half of all of the people who had an overdose death. Let me see if I can turn my volume up a little bit for you. Is that any better?
I think it is a little better.
Okay. Okay, so I'm just going to start here. The VA had a retrospective analysis to find out half of the overdose deaths that happened between 2004 and 2009 had both a benzo and an opioid on board. And so from that, they said, absolutely, there's an increased risk between these two. Let's watch this a little bit closer. That was actually what prompted this black box warning to come out. So it's something that we need to be watching very, very closely. I've got a couple examples of benzos listed up there, but basically anything that ends in Z-Pam or Azalam or something like that, it's always going to be a benzo. So it's something to watch for, but basically we want to avoid that combination if possible. So if we can do one without the other, great. There's always going to be patients that come in, and we're always going to be weighing out that risk and benefit. But patients need to be aware that there is a risk, and so they need to have that counsel point of, hey, if you're on both of these medications, you're at an increased risk of death and respiratory depression and all these bad things. So the patient needs to be involved in that decision-making process if they are going to stay on that medication. I'm sorry, both of those medications. For PRN usage, we're always going to be trying to use the minimal of both those medications, and then naloxone should also be on board for those patients. But withdrawing from opioids, so if at some point we are going to stop an opioid, if someone's used to that medication in their system and we're all of a sudden going to take it away from them, they're going to experience withdrawal symptoms from that. Withdrawal from opioids, it's been typically described as the worst flu ever. It's typically not life-threatening, but some patients may disagree. There's always going to be a lot of bad effects from it. It would be different for neonates. Situations like that would be a lot more of a serious situation, but for most patients, it's just going to be kind of a diarrhea, nausea, vomiting, irritability situation for them. Make sure they're staying hydrated, but not going to be the end of the world, but definitely will be in some discomfort. I want to emphasize here, though, the difference Physical dependence is when you're used to a medication being in your body. As soon as you take that medication away, your body's going to respond with withdrawal. That happens with a lot of different medications, opioids in particular here. That does not mean that they're addicted to the medication. It just means that their body's physically dependent. Now, opioid use disorder, that is going to be the differentiation here. That is when someone is no longer in control of the medication. The medication has more control on them. They're starting to have some failure to fulfill obligations to work, school, home. Basically, the medication's controlling their life more than what they are at that point. So, very big differentiation there. Just because someone is dependent on an opioid does not mean that they are addicted to an opioid. Next slide. Okay, so like what was mentioned earlier, the CDC, they came out with a lot of different guidelines back in 2016. They also came out with a pocket guide for tapering off of opioids. They have a lot of suggestions for the way to handle opioids, and this is one of the. It's just a couple-page document. It's readily available if you needed access to it, but I'm going to just highlight some of the features of that document. So when do we consider doing a taper for opioids? If the patient requests it. Now that doesn't happen all that often, but I think more so now we are seeing some patients coming in and maybe being a little bit more concerned of the opioid epidemic. And as an example, that when Prince passed away in 2016, we did have a patient came in and said, hey, I know I'm on a medication that's similar to what Prince was on. I want to be tapered off. And so in that situation, absolutely, we help the person slowly taper off and reduce their withdrawal symptoms and allow their body to kind of reset themselves to their new pain level. So you may have people that will come in and request to lower their dose and absolutely jump on board. That's should have actually pretty good outcome most of the time. If they don't have functional improvement, so like Dr. Smith had mentioned earlier, a lot of times people have a pain agreement when someone starts an opioid medication. With that, if they are not meeting their functional improvement goals, or they're not seeing pain relief, and they just need to keep potentially increasing their dose or needing something more than what's being provided for them, that might be a situation where the opioid pain medications are not working, and we need to figure out a different plan for them, and in that situation need to taper down. The CDC is going to recommend dosages above 50 morphine milligram equivalents with or without benefit, or if they're on a concomitant benzodiazepine. Now, again, we need to always be weighing the risks and benefits. I don't think it's smart to just instantaneously stop someone if they're on one or the other. Both of these need to be tapered appropriately, but you always want to be doing that risk-benefit ratio with the patients and have them included in the plan. If they show signs of substance abuse disorder, absolutely. If they've broken that pain agreement, if something's popping up on the Iowa PMP that seems out of order, if there's anything that just kind of doesn't seem right, it's a time to maybe reassess that patient's plan. If they experience an adverse or serious, an overdose or a serious adverse event, a lot of times this is going to be some type of a respiratory event. And it can be the person's completely passed out and needs to be revived with naloxone. If that's the case, it needs to be reassessed for their dosing at that time to make sure that we're maybe coming back with a safer dose for them and tapering down to an area that won't be on the brink of putting them in that overdose again. And if they have signs or symptoms of an overdose, this would be more of like the over-medicated. A lot of times I'd see these people as kind of a glazed over look, sedation, confused, slurred speech, something along those lines. I think we all have seen someone that's over-medicated at some point in our career, so it's definitely a time that the medications maybe need to be adjusted at that point, just so it should be adjusted at that point, just so we're making sure that they're safe and getting on the appropriate doses for themselves. Next slide. So again, with the CDC guidelines, this is what they are suggesting for an appropriate taper. Generally speaking, we are going to do a 10% reduction per week. or per month. If the person's been on it a very long time, 10% per month, this will help. The slow dose decrease allows their body to kind of naturally reset, and slowly be able to, their body might compensate a little bit and cover some of the additional pain that they're having during that decrease. So it's, if you do it slowly and over time, sometimes they can actually have a similar or the same pain score once they get to that end dose. But again, that slower dose adjustment, we should be avoiding all of the withdrawal symptoms and potentially having similar pain scores. If need be, we can always consult a specialist, especially in high-risk patients. If you're on a lot of different medications, if they're on a concomitant benzodiazepine or something along those lines, it's always good to more, two heads are better than one, and so the more people you can have involved, I've been always very happy to help out if there's ever been anyone looking for those dose adjustments, and I know pain clinics sometimes are willing to send out recommendations for taper off doses or taper down doses. Sometimes, again, the two heads are better than one. Sometimes the psychosocial support, a referral to a mental health provider, or even encouraging positive reinforcement yourself with the patient, being that pillar for them to lean on, so that they're making sure that they get all the help that they need, and know that they're not alone in the process. Next slide. So considerations for this by the CDC. So we always want to take the patient's response into consideration. So sometimes they're going to feel like a dose adjustment was way too much. It's important when you hit that point, when you've dropped a dose and they're saying they're feeling withdrawal, they're having increased pain, it's important not to go back up in dose. It's important to hold that dose and maybe take it a little bit slower for them, but allow their body to kind of readjust. If you bump the dose back up, it's kind of going to be sending first of all, their body's going to be used to a higher dose of the medication. Then again, they're not going to be working on that slow full taper off. So it's just kind of sending mixed messages to the patient, and it's best to just hold that dose and then revisit the next lower dose when it's more reasonable for the patient. But dose and intervals can both be adjusted. It's kind of tough to get to that 10% all the time with just the tablet strengths available. So sometimes you might have to adjust the intervals in between when they're taking it. Now, patients should be expecting to feel pain in between. What we normally would counsel patients is these pain medications have been used to help reduce your pain, but you're going to have breakthrough pain throughout the day as is. So you need to be kind of anticipating that you're going to have intermittent bits during the day of increased pain. So if you're changing the intervals a little bit, you might want to reiterate that there's going to be some pain breakthrough for them, but to just anticipate that and work through it. Next slide. So during Hurricane Katrina, Louisiana being the mainstay for this, they had a very high prescribing rate of opioids, and so when the people went, the kind of the first responders went down for physicians and pharmacists and nursing staff, they kind of had to make a hard, fast protocol for tapering people off of their medications, because pharmacies aren't going to be open and there's not going to be a whole lot of supply of their normal medications. So this was kind of what one of the options that they developed to do a hard, fast taper for someone to minimize withdrawal symptoms. It's very aggressive, and they're going to have pain, and they very well could have withdrawal symptoms, but it's going to minimize those withdrawal symptoms. Next slide. And next slide when you're ready. A couple things to think about. So one thing that Dr. Smith had mentioned, you always want to refer to the package inserts. Well, I would definitely encourage to refer to the package inserts for methadone and fentanyl when doing a taper off. They have very specific manufacturer recommendations for doing the taper, and it's a lot of times a little bit slower for those. Milligram availability for tapers, it's always going to be tough to get to that 10% reduction or whatever percentage you're trying to get to. I would just suggest, as long as you're getting close, or something that's reasonable. But another thing you need to keep in mind, and this is probably a four-letter word for a lot of you out there, but prior authorizations. If you needed a prior authorization for that first opioid prescription, you're going to need a prior authorization for each of those individual steps down below. So it's definitely something that you want to make sure that you're keeping in mind before doing here's a script for next week, here's a script for the week after that, here's a script for the next week after that. Each of those are going to require its own prior authorization, so you better anticipate those before handing them out. And then what's the reason that we're doing the taper? So some things to think about. It's always going to be up to the prescriber on how they want to do that taper off. Patient needs to be involved in that process, but there's times where you might not use any opioids for tapering off. It might be a situation that you only use supportive medications. We're going to mention those in just a minute, but the one example I can think of specific to this is I had a physician come to me and they said that the patient's family had been calling in saying that the patient had been selling their medications. The physician instantly went to a taper off regimen for this patient. However, the family kept calling in and saying that she's just selling off all of the taper off medications as well. And so he said, what do I do here? I want to protect my license. I don't want to abandon this patient, but I want to do it safe too. And so for this patient, we just went to do supportive medications for withdrawal symptoms. And that should always be considered an option as well. So next slide, we'll talk about the withdrawal meds that can be used. For sleep, we can use trazodone. For pains, NSAIDs can be recommended. Diarrhea, so loperamide is an over-the-counter medication that can be used. It's actually structurally similar to opioids, and technically speaking, it is an opioid. However, it does not work in the brain, so you don't get the same pain effects from it. It does have its own abuse potential, but it's an over-the-counter product. As long as they're using it intermittently for a short time, that is an option for them to potentially have some alleviated effects from diarrhea during the withdrawal symptoms. Anxiety, irritability, hydroxyzine, and quetiapine. We do not want to start up a benzo in this situation. That would be almost trading out, depending on the situation, it could be trading out one addiction for another. So something to avoid. Nausea, vomiting, everybody's used to those medications. And clonidine is by far the standard that we should be using. This is going to be the mainstay for many different withdrawal symptoms. But if you're going to do a medication and a single medication, clonidine would be one of the better ones for withdrawal medications, and it kind of has listed off what it helps with there, but it would always be tapered with symptoms. A lot of times I would see 0.1 milligrams 3 times a day and then tapered down according to symptoms as they're getting through it. Next slide. So support. We want to make sure that these people during their taper off are getting all of the support that we can help them with. So positive reinforcement from us. If we can consult with, if it's needed, you can always consult and put two heads together. Again, unidirectional tapers need to be emphasized at the beginning, and make sure that there's not that slip up of going up in the dose. Support groups, chronic pain groups. This is something that we try to utilize at Broadlawns. It's very helpful for patients to be able to talk to other patients, and we have had a lot of times a lot of success when they can kind of bounce ideas off each other and offer each other support, or know kind of the process that happens, and be able to talk through it. They can a lot of times communicate with each other a little bit easier than sometimes they can with a healthcare professional. Encourage family support. So I would say that a lot of times families are encouraging of the patient to lower the dose. And if they're on board, it's going to help out so much more with the patient. I mean, this goes for anything: smoking cessation, quitting alcohol, anything that if the family's on board, it's going to help out significantly. And then empowering the patient, just making sure that they're on board with the process, that they understand kind of the steps that we're going to be looking at, and making sure that they know that they're going to be a part of the decision-making process, and we're working with them to get them to a safer dose. Next slide. So opioids and benzos are bad. I think everybody knows that. I just want to make sure that it's really emphasized here. Patients need to be described that it's going to increase their risk of death just being on that combination. So and again, they can be part of the team making decision on that, but they definitely need to be aware, and it needs to be documented that they were told of that increased risk. Tapering opioids. So again, the CDC, you're looking at a 10% reduction weekly to monthly. And then one of the Katrina protocols is a 25% weekly or bi-weekly. So it's either a month or 2 months for that full taper off for the Katrina protocol. And then the supportive medications, again, clonidine would be the mainstay for that. I've got my references on the next slide, and then I'm open to any questions.
Let's just take a look at the chat. I didn't see any questions, but I'm going to double check. Please know you can type any of your questions into the chat box, and we will address those with our group. So I did make a mention, really making sure the patients, and I would say families as well, are engaged in knowing what to expect when you're doing a taper down with that breakthrough pain. I think that's just so good to assure, and making sure you're getting that interaction back and forth with that engagement. So Jarek, thank you so much for presenting today. We really appreciate it. I think that we have had some tremendous information shared with us today. Some was a review, some was a little bit more detailed. The references on the slides will be placed on Innovation for everyone. And I wanted just to kind of move through a couple quick slides before we end our conference today. We will have the webinar number 3 for the opioid project, breaking down the silos and mobilizing your team. That is scheduled for March 29th from 11 to 12:30. And I have the registration link on there as well. And then we have another training webinar like the one today. It is April 12th. Again, it will be scheduled for 1 hour and 30 minutes. The Untold Stories of Diversion. And I think that might be one that we get a lot of people engaged in. And I think it's going to be an eye-opener for people to recognize that there could be things happening that we haven't tuned into. So again, a reminder for this webinar, because we are applying for contact hours for nursing. You will have to be registered and on the webinar the entire time, and again, utilizing your own email address. And the next piece is just reminding you, for our opioid guardianship program, you can feel free to contact Sarah Durr, our pharmacist here on staff, who works with the medication management. She's our program lead. Or myself, I'm Lana Comstock. I am one of the Hospital Improvement Innovation Network improvement advisors. So please feel free to reach out anytime. And just a quick look again for any chat comments, and I see none. I really, truly appreciate everyone's time, and I will be ending our webinar at this time. Thanks, and we'll see you on the next one.